Okay, so at this time, I'd like to introduce our first speaker, Dr. Jacqueline Cruiser. Dr. Cruiser is an assistant professor of medicine in the Division of Allergy, Pulmonary, and Critical Care at the University of Wisconsin-Madison School of Medicine and Public Health. She's also a pulmonary and critical care physician and hospital ethics committee member at the University of Wisconsin Hospital. Dr. Cruiser graduated from the University of Chicago Medical School and completed her internal medicine residency and chief residency at the University of Wisconsin. This was followed by a fellowship and master's degree at Northwestern University in Chicago. Dr. Cruiser's research interest involves technology and interventions that prioritize the needs of patients with critical illness, their families, and the professionals who care for them. Please join me in welcoming Dr. Jacqueline Cruiser.
Thank you so much, and thanks to everybody for being here today, and thanks for the invitation to come and speak with you about a little bit of my work. So I wanted to start today with this image, one that's probably familiar to some of you in the room. I know we have a variety of healthcare professionals from different fields. So if you aren't familiar, this is an intensive care unit room. And I just want you to imagine walking into this room. And what are you noticing? What do you see? I suspect you probably noticed the ventilator in the back. The green thing in the middle is a dialysis machine. There's lots of drips. There's a monitor. Thankfully, we don't use these beds very often anymore, but this in the center is a specialized bed for patients with very severe respiratory failure to put them in this prone position. So this technology has saved countless lives and has been incredibly important. And maybe I'm biased because I am a critical care physician. But I also hope some of you are now thinking about what might be conspicuously absent from view as you walk into this ICU room. Our patient, their family, and the incredible numerous members of the interprofessional healthcare team that is taking care of this person who's very sick. And while this technology is how we design intensive care units and perhaps how we've even built hospitals to support, one of the things I would like to convey today and perhaps argue for us all is that we need to take a step back and think about how the technology-focused intensive care unit and perhaps acute care system and maybe even larger healthcare system design decisions make it more difficult to keep the patient in view and in the center of our view. And so this is the system we work in. And today I want to talk about a particular aspect of what our system is composed of, and that is our words, our language, and our common vernacular. And so I'm going to talk about two particular words today. One is the word need, and the other is the short phrase goals of care. And I'm going to argue and hopefully convince you by the end of today that these very common words not only shape clinical care in perhaps important ways, but help teach us and help us reflect on the way in which our healthcare systems and the implicit goals of our healthcare systems are built into our day-to-day work. I'm going to show you a little bit of evidence to suggest that this language reflects the embedded care processes, and that these care processes often bypass moments that are well suited for meaningful deliberation. These are moments that are well suited to bring the patient back into view, but sometimes we miss them. And I'm going to propose a new strategy that we've been thinking about in our group that may help us intentionally reshape our patterns of care and bring our patients back into view. I don't have any personal financial conflicts of interest. I would like to disclose that my spouse receives honoraria that aren't related to this. And I will be presenting work today that's been supported by the NIH and 2 other grants. But perhaps more importantly, I would like to disclose that most of the work that I'm going to be sharing with you today is strongly influenced by my position as a critical care physician. So this is my view, and often I will share with you some of the missteps that I've made and things that I've learned along the way about how I use language and how now I've perhaps learned to think more carefully. So to need is to lack something essential. And in healthcare, in acute care, in the ICU, by definition, our patients lack something essential, and often something essential for life. Life-sustaining treatments is what we call the technology that we use in the ICU. So it's not surprising, at least to me, that need is a very common word that we use at the bedside. So I suspect these phrases all of you have heard. If her breathing gets any worse, she will need to be intubated. He needs a central line, a special IV catheter in his neck, so we can give him blood pressure. If she doesn't make any urine soon, she will need dialysis. And if she can't be extubated soon, she will need a trach. But perhaps when we use the word need, and we are trying to convey the link between a particular healthcare condition and its available medical intervention, we may not be conveying, and our patients and their families may not be having the same understanding that we have. And so I want to tell you a story about a patient that we learned. We were doing research and we were asking the family members of patients who had been in our ICU to come back and tell us their story after the patient had left the ICU. And so a daughter of a patient who ultimately died in our ICU came and was meeting with our research team, and she told us this story. She said she was at home one day. Her mother had been in the hospital for weeks with an advanced cancer that she knew was not curable. And someone called her, the physician called her at home, and this is what the daughter told us. The physician called and said, either your mom needs to be on the ventilator or she's going to die today. And then the daughter went on and told us a little bit more about her mom. She was a retired ICU nurse who had said throughout her journey with advanced cancer that being on the ventilator was the worst possible thing that could happen to her. And she knew that she told everyone in the moment that she did not want to be put on a ventilator. But it was the opinion of the doctors at the bedside and her oncologist that she wasn't capable, she didn't have capacity of making this decision. And so her daughter decided to go ahead and pursue invasive mechanical ventilation. And she told us, I trusted the doctors more than my mom. Because who wouldn't give their loved one what was needed? And perhaps we can sort of take a step back out of the healthcare arena and think about why we use the word need, what scenarios. So here's a stick figure, and this person does not have water. That seems like a pretty boring thing to have up on my slide, perhaps. And if I told you this patient needs water, what comes to mind is an entirely different set of facts, and not just facts, but a call to action. And not just a call to action, but a call to an action of specifically what to do. Get this person some water because he needs water. And so in healthcare and in medical education, I can tell you, we're often taught what are the indications to mean that dialysis is needed? How severe should the respiratory failure be to say that we need to pursue invasive mechanical ventilation or a form of life support? But perhaps when our families and the patients that we're talking to hear us say a person needs to be on the ventilator, it is hard for them to disentangle the clinical scenario from what we are perhaps offering for them for potential options. So here's really the crux of the argument that we've put forward in a paper where we went into this use of the word need, in particular in acute care, that need creates an inextricable link between the problem and its action. So if her breathing gets any worse, she will need to be intubated. And even though as clinicians, as healthcare professionals, as folks who are in this space a lot, we may understand that we want to first present that her breathing is getting worse and she needs to be intubated, and then take a step back to think about whether or not we should pursue mechanical ventilation. It's perhaps not so surprising because of this, that our patients and our families are having a hard time disentangling this call to action. And so perhaps it's not surprising then that we end up in a space of conflict. And so what could we do instead? Because as clinicians, we are trying to convey the severity of the acute illness and the decisions, and sometimes the very acute decisions or emergent decisions that need to happen. But noticing when we're inclined to use the word need is perhaps the most important thing, to create space. And I can tell you, as an ICU physician, I often have to walk through and talk through these things quite quickly, but this can happen very fast. You don't need a lot of time to create space. And so instead of saying she needs to be intubated, you might say, the problem with her breathing is getting worse. Can we talk about what this means? And if I think back to the patient I told you about, what this means is that we're worried that your mom's advanced cancer is progressing. She may have a pneumonia as well. She may have an infection in her lungs as well. And we're hoping that the antibiotics might help with that. But we don't know yet whether or not she's going to be able to get better from this. And this intentional space then creates a moment to acknowledge that, and we may say in this moment, I'm worried she might die. And in that space, there's an opportunity for acknowledging emotion and disarticulating the fact that her breathing is getting worse and we're worried about what's happening from this thing that we have, which is mechanical ventilation. And once you've created that space, then you can say, can we talk about what to do next? And what to do next, it depends on the clinical context and what you might say here. But again, for the same patient, you might say, we could try using mechanical ventilation and see if over a period of days, the antibiotics help and her breathing gets better. Or sometimes people tell us that mechanical ventilation is not okay with them. And we have lots of things to offer to take care of your mom and make sure that we prioritize her dignity and comfort. And you may consider that this conversation could have gone different for the patient that I was telling you about. And so this one word need, I guess I'm not making the argument that the whole enterprise of how we use life-sustaining treatment in the ICU rests on sort of this one linguistic issue, but I do think it highlights perhaps a larger issue that is at play. And so this is a quote that I really like. This is from a medical anthropologist. She was a professor at the University of at UCSF, Sharon Kaufman. And she wrote that patients get put on a train of aggressive interventions that is very difficult to stop. Diagnostic tests confirm the need for interventions. Procedures become appropriate by default in this organizational scheme. And we've borrowed from her work, we've learned from her work, and also from what is known from decision psychology and other medical social sciences, and put this model into the ICU, and we call this clinical momentum. And so this is that feeling that there are latent system level properties of care that even when we sit down and we use our best advanced communication strategies, it feels as if we're trying to undo an understanding that has already taken hold. These deep system level implications that there is a need for intervention. And we are trying to use our communication to put a stop to this train. So people use the analogy of a speeding train on or airport walkways with sides so high that you can't get off, or an escalator. So there's lots of different metaphors that social scientists have used to describe this phenomenon. And so just to bring it back to the ICU space where we started, we can consider a patient who comes into the intensive care unit with breathing problems on day one. And because their breathing is so severe, we start mechanical ventilation. And by ICU day 14, perhaps they have not gotten better the way we had hoped. And so we sit down to talk about whether it would be okay with the patient to pursue long-term ventilation, and we talk about pursuing a tracheostomy. But I think most of you in the room probably recognize that this sort of simple reductionist view of an ICU stay is a complete fiction. And instead of this, it looks like this, where you start with mechanical ventilation, but then the patient goes into shock, and we put in a central line, and maybe they need dialysis, or maybe they need a blood transfusion, and a new pneumonia, and an X-ray. And by ICU day 14, there is this sense that each of these disarticulated moments, perhaps we pursued informed consent in the way that we have been taught for each of these procedures. And yet by the time we get to ICU day 14 and we're sitting down for the family meeting and we have a place where we can no longer see our patient through the medical interventions that we've been providing, it's at least not surprising when we take a step back that we are often in a space of conflict and confusion about how best to pursue care for our patients. And I think there's really interesting work, and this is a study that came from Renee Boss's team in the PICU setting, and I think it also applies to adults as well. And this was some qualitative work. And I think, and I reproduced, they had a figure. So if anything is unclear about this figure, it's on me. But if anything you feel like is a good insight, it's on someone else. But the idea is that when a patient comes to the ICU, as the healthcare team, as the clinical team, we are focused on diagnosing the problem, figuring out why they're sick, figuring out which interventions we have to treat them, and trying to do our best to help the patient recover. When families come into the ICU, they're focused on their child, on the person, on the patient, who they were before they came to the ICU. And over time, there's a differential effect of clinical momentum on the ICU team and on the family. That while the family is in the ICU, they come to rounds every day, they learn about creatinine level and PEEP and how much oxygen they're on, and they start to learn how we talk about how the patient is progressing over time. And the clinical team, when they see that the patient's creatinine isn't getting better the way they'd hoped, or perhaps it's stable, and we've had a relatively difficult to interpret physiologic change of unknown significance, we start to worry that the patient might be dying. And then there's an inflection point where the family learns to focus on what we've been focusing on all along, which is the clinical numbers. And we come to them and want to have a moment where we step back and talk about what was important to the person. And I think this really helps illustrate how we end up in conflict over time, despite everybody working as best they can to try to take care of the patients. And perhaps that this conflict it gets perpetuated unintentionally. And so just to sort of summarize this piece of the talk, the idea is that need and this notion of need, or this notion that our interventions are inextricably linked to medical problems, creates and promotes this clinical momentum that sometimes can make it difficult to keep our patients in view. And instead, recognizing that linguistic feature and perhaps this bigger system level feature, we can use these moments as intentional places to pause and create space. Can we talk about what this means? And separately, can we talk about what to do next? So I'm going to move on now to a different phrase to illustrate a slightly different point. And so I suspect in this room, I don't need to make this point, but belabor it, is that goals of care is a ubiquitous phrase in healthcare. And I bet everyone here has heard this. So you can see it, this is from a public-facing patient campaign. Have you had your goals of care conversation today? It's labeled, there's nonprofit organizations that are completely, are aligned around the concept of goals of care. There are large health systems that put out system level promotional efforts and system level efforts around promoting patient goals of care. And even this is publicly available. This was a legal and risk management clinical in-service about goals of care. So this isn't to say that this is not a term that's helpful, but it is a term that is very common. and has sort of pervaded the healthcare system. And this is just, we did a systematic review looking in the healthcare literature, and this is just demonstrating that it's not only common in the public-facing space, but even in the healthcare literature, the number of citations has risen dramatically that has this exact phrase in either the title or the abstract. And so why am I telling you all of this that you probably heard? Well, in that same paper about goals of care, we learned, and we used qualitative discourse analysis to sort out what do people mean when they say goals of care. So in the literature, in the scholarly sort of shared definition, this is what we learned that they mean. It refers to the overarching aims of medical care for a patient that are informed by the patient's underlying values and priorities that are established within an existing clinical. So they have to be related to what is at hand. And then they're used to guide decisions about medical interventions. And so here's a visual schematic of sort of how this notion, at least when it is used in the scholarship, is used to convey the relationship between these different things as we make decisions for folks in relationship to their medical care. But then we realized, and we were doing a lot of qualitative work with clinicians and looking at health records to try to understand how this notion of clinical momentum played out in the ICU. And we saw, unsurprisingly again to this group, this phrase over and over again: goals of care pending, goals of care in the notes, conflict around goals of care. And we started to wonder whether there was a completely different use of the term goals of care in the clinical context as compared to the scholarly definition. So we did two separate studies. We both asked folks directly and we analyzed how they used this phrase in health records. And here's some of the primary things that we found from our data. First is that clinicians use goals of care as a signal as they end of life. So an ICU nurse in one of our studies said, the phrase goals of care is synonymous with an end of life, end of the road discussion. We've tried everything. Let's have a goals of care discussion with the family to explain where we're at. Similarly, at this point, we've established that all hemostatic interventions have been futile. Agree with the primary team's effort to address realistic goals of care in the context of this end-stage multi-system organ failure scenario. And not only do they use it to signal end of life, but they also use it as a signal that their view on end of life is not met by the family's view, and that there is perhaps a conflict. So here, another position. I've seen goals of care used in situations where the care team feels that prolonged ICU care will be non-beneficial, but the family's not in agreement. Oh, this family needs goals of care. It's implying that the family's not on board with what we think is right or appropriate. And further examples here, we will continue to press for resolution of goals of care. And here, we're looking for a family meeting with ethics. I'm sure this is something that many of you have heard, to try to work toward a more mutual goals of care decision. And the other thing that we learned from the clinicians, and they were quite upfront about this, is that these signals about death and conflict are meant to be implicit. We sort of have this secret, an implicit understanding within ourselves as to what we mean when we say that. And so what I'd like to suggest to you is that there is an interesting tension here between the scholarly and public use of the phrase, which on one hand seems very clear. There's not a lot of conflict around this, and it is used in public-facing campaigns. Have you had a goals of care conversation today? And, oh, this family needs goals of care. And I think one of the things that our work and the thing that we have to work on is addressing this tension and where it came from, and what are the things we can do to help resolve what feels like an intractable conflict between where the clinicians are and where the scholarship is. And I like this quote. This was a paper written by a very wise nurse also examining this phrase goals of care. And I think what she wrote here is something for us all to think through. What she said is that the implicit goal of healthcare is usually cure or survival. And so in many clinical areas, goals of care are reasonably taken for granted and not explicitly stated. And as we heard in our data, they're not explicitly stated until we're at the end stage multi-system organ failure scenario. And I think I would argue that that's not a great place to try to accomplish a patient's goals and priorities. And so now I'm going to, after sort of focusing on these words, I'm going to show a little bit of evidence about how these pieces of language fit together in our embedded care processes. And so I'm just showing you the cover here of a white paper that was published over 20 years ago now. So this recognition that failures in healthcare are more often related to systems and processes than individual human error has been around for a long time. And there's lots of folks that have been working in process improvement and focusing on how do we build robust and wise systems instead of continuously working on individual level error. And so this white paper, again, written about 20 years ago, was saying people have been doing this in industry for a long time, using systems engineering and human factors engineering approach. And so their argument was that we should bring this system level lens and the way of viewing complex systems to healthcare. And so one systems engineering tool is known as a process map. And some of you may have worked with this in your organization or your administrative roles. This is just an example of a process map from NASA. And as it turns out, NASA was a very early adopter of systems engineering. This sort of organizes most of how they run space missions. And so one of the purposes of process maps is to show how outcomes are produced. And so you can take any place and you can travel through each of the different steps, and there's decision points, and you can figure out what are the steps along the way to get to a desired outcome. The other way that engineers use this tool is to examine existing complex systems and figure out where it's going wrong. Where are the vulnerabilities in our current complex processes? And so you may look at this and say, oh yeah, that looks like relatively complex. There's mission feasibility, that sounds important, and lots of boxes here. But this is actually a very small part. This is the NASA mission feasibility process. And you can't read it, but you're not supposed to be able to read it here. But the purpose is to say this is a tool that can capture complexity and organize complexity in a way that it can be understood. And so we use this tool to try to understand how clinical momentum was playing out in the intensive care unit. So we went through a variety of data collection processes, including looking at the health record, doing direct observations in the ICU with engineers, and interviewing and holding focus groups we had 70 total participants that represented 17 different roles in the ICU, from the ICU team members, these were nurses, chaplains, social workers, physicians, our specialty palliative care team, folks from the ethics committee, surrogate decision makers, patients. And they helped us create a process map. So I'm not going to show you our map because it looks kind of like the NASA map. But I am going to show you a few key pieces of the map where we thought it really helped us understand the process vulnerabilities, those moments where the current process seems to fail, which are opportunities to improve the current process. And so if you take sort of the process mapping notation, usually processes start with a yellow oval. So this is our patient here with respiratory failure. And decision points are represented in these maps as diamonds. And so what you can see here, this is a very sort of simplified moment of the decision or the deliberation period around starting mechanical ventilation. And you may also be noticing here that it is in a dashed line. And the reason that it is represented in the map as a dashed line is because this decision point is often skipped, or it's very frequently skipped. And that is sort of the dominant through line that we found, this sort of blue line where the deliberation is even bypassed. And when the deliberation points are bypassed, the system, the process either contributes to initiating or continuing life-sustaining treatment, because the alternative is end of life care. And so we walk this out for the entire course of a patient's ICU stay when they have breathing trouble and respiratory failure. So after this first deliberation moment, there's a second point where we do a more comprehensive evaluation, and there's another deliberation within the first couple of days. And this period as well is often skipped. And so mechanical ventilation is continued. And then we get into sort of the cyclical ICU day rounds where each day we reevaluate the physiology. Are they better? Are they worse? Are they the same? If they're better, they kind of get through this whole thing and go off the top to the extubation green oval. If they're stable, they keep going around in this circle until they worsen to the extent that a deliberation period is triggered. I'll come back to that. A deliberation period is triggered. And so what you can see here is that the process, if you follow the blue line, the process promotes continuation and escalation of life-sustaining treatment unless these deliberation moments are acted on. And so we also gathered a lot of data, a lot of qualitative data about why these moments were being skipped. And so this was, to me, was some of the most important piece because it's where I've learned these are the opportunities we have to change. So we have these 4 naturally occurring moments in the cadence of ICU care to stop and pause. And when and how could we reinforce these dotted lines? So what we learned, and this was one of the quotes, honestly, that continues to haunt me, from a surrogate decision maker who came back. And she knew her cousin did not want to be on the ventilator. And she told us, I didn't want to sound like I was giving up on him or that I didn't trust their ability to cure him. Me bringing it up was not the right thing. So she didn't have the agency to enact a deliberation moment. An ICU nurse told us, if the attending that's on or the fellows that's on, if they don't really do a good job connecting or empathizing with patients, I might not address it with them. So this was a nurse that knew the family thought we should perhaps pause and have a deliberation moment. And the nurse decided not to bring it up to the attending because of their perceived skill or lack thereof. And then we rotate all the time in the ICU, at the nurse level, at the physician level, our chaplains rotate through, and each system perhaps has different rotations, but this is sort of now characteristic of acute care medicine. We will drop the ball in a way and say, well, I'm only on for the weekend. I don't want to get involved. I'm only here for one shift. And so we end up waiting for the deliberation moment to address realistic goals of care in the context of this end-stage multi-system organ failure scenario. And so far I've made sort of 2 points, which is that the language of need and this inextricable link between very severe clinical problems and the medical technologies that we have contribute to this larger process and system level influence of clinical momentum that plays out over time. And that we have a current process that has well-suited moments for deliberation within its cadence, but they are often skipped until this moment of physiologic failure or a moment of physiologic crisis, which is now what we identify as goals of care. And so perhaps it's not surprising that clinicians think goals of care means end of life, because that is how we have learned, and that is how our processes and our systems promote the use of this term. And so finally, I'm going to move on to a strategy we've been thinking about as a way to help overcome and perhaps reshape and intentionally reshape the patterns of care that seem to drive how life-sustaining treatment is used in the ICU. So namely, this is an approach termed time-limited trials. So I'm not sure if everyone in the audience is familiar with this phrase. It is a phrase that is relatively common, but not everybody uses it. But I suspect as I start to talk about strategy, it will be familiar to you. And so I've offered to you this current date where our moments for deliberation are these dashed boxes. They're there but they're inconsistently acted on and sometimes are skipped because we're only on for one shift. And so can we offer a more explicit, a more robust process that isn't so vulnerable to these system and process level failures? And so that is, in my view, what perhaps a time-limited trial can offer. So what is a time-limited trial? This is something that has been talked about in the literature since the 1990s. I had the opportunity to participate in a committee from the American Thoracic Society. We realized that there was a lot of different definitions in the literature. And so we went through a consensus and a Delphi process with a variety, about 100 experts from across mostly the United States. But we came up with a consensus definition of what is this thing that people have been talking about. And this is what we came up with. A collaborative plan among clinicians, a patient, and their surrogate decision maker to use life-sustaining therapy for a defined duration. After that duration, the patient's response to therapy then informs the decision. And usually the next steps would be something like continuing care that's directed at recovery, transitioning to care that's focused exclusively on the patient's comfort, knowing that the end of life is near, or extending the trial's duration. And you may think that this is a very wordy definition and so on. I was at a lecture last week about asthma, which as a pulmonologist, I felt like asthma should be really pretty easy to define. And they showed the definition. It was 3 slides long. So then I felt pretty good about it. And so the other thing that we did in this consensus group is say, so here's, in essence, this is what we think a time-limited trial is theoretically, the concept of a time-limited trial. But what would it mean to do a time-limited trial? Because there's also a lot, and there's very little empirical data in the literature about whether time-limited trials help, what they actually are, how people are using them. And so we thought it would be useful to define the essential elements. If you were going to sit down and say, okay, I think this is a good patient to pursue a time-limited trial, what might you do if I'm arguing that this ought to be a structured, explicit process? So first, consider the role of a time-limited trial, and in particular, the 2 key features, the patient's goals, what you know about their goals and their priorities, and the clinical context at hand. And then importantly, sit down and plan the time-limited trial, how you will conduct the trial. And this has to happen with the patient or the surrogate. And I suspect this isn't a point I really need to underscore here, but I will tell you, when talking with intensivists and critical care physicians about time-limited trials, they will say, all of ICU care is a time-limited trial. What are you talking about? Like, this is not, anything new. But I think this is what the explicit structured process is, not only for us, it is also for our patients and our families. And it's that process of making explicit our expectations and what we think could and might and is likely to happen, and make that process explicit with patients and families. So that collaborative nature of the time-limited trial is really key to this process. And then you pursue the trial and you support the patient, the surrogate, and the other members of the healthcare team during the trial, and you revise the plans as necessary. And finally come back and reassess how the patient is responding to life-sustaining therapy. And within each of these 4 phases, there's specific things that ought to be done if you're going to consider your care a time-limited trial. How long will the trial last? What are your milestones that would suggest the patient is improving as we hope, or perhaps not improving, or even deteriorating, getting worse? Importantly, and this was sort of very key in our committee members, and as I've been talking to lots of folks about this, tell other people about your plan. Perhaps one way to do this, and this is recommended in the document as well, is to document in the healthcare record the time-limited trial. But nurses often don't. You may have a very good discussion with a family and plan a time-limited trial, and if you don't tell anybody, it's hard for the other members of the interprofessional team to be able to support and participate in and help plan that trial, perhaps ahead of time, or support the trial through its duration, and provide consistent and clear set of expectations for our patients and their families. And then finally, to come back and reassess the response to therapies and consider what might happen next. So, as I said, this has been talked about since the 1990s in critical care literature, in ethics literature, and palliative care literature. There's been very little empiric studies of this approach. In one ethnographic study in adult ICUs, the range was between 8 and 27% of patients. In another study where they just looked at family meeting transcripts, they saw this approach to care being offered in about 13%. So it's not often, and it's also not never. So it's out there and it's being used. We conducted a one-year study in our ICU. We looked at every single patient on the ventilator receiving invasive mechanical ventilation. And we asked the attending physician, would you consider this care? We gave them our little definition. Would you consider this patient's care at time of trial, yes or no? And so we found about 20% of our patients in an academic adult medical ICU were receiving this approach to care. The vast majority of those patients ended up dying. And we saw there was important differences. They were offered in patients that were older, sicker, had higher comorbid burden of illness before they came in. SOFA score is a measure of how acutely sick they are that's used in critical care trials. So similar degree of acute illness, but overall, there were differences in the population. And I certainly don't want to claim here that folks died because of the time limit trial. This was an observational study, so we were just looking to see what's happening. I suspect, and I think that what we're doing in sort of future studies is to try to sort out, this is a strategy, perhaps you could tell by how it's defined, that physicians primarily use in patients they're worried are going to die. So this is sort of a selection bias, or this idea of confounding by indication. And I think one of the really interesting things we found in our research is that only half of ICU physicians use this. So we see a lot of variability. So each physician on this bar, each letter on this bar graph represents a different ICU physician. The green line shows you how many patients they saw over the year. And then the yellow line is how many time-limited trials they conducted as the attending physician. And you can see it's not determined by volume. And then it's highly variable. And only 50% of the physicians in our group ever used this strategy. 50% never did. But what we really don't know is what's the best way to conduct a time-limited trial. And we have this jumping off point. We've tried to define it in an operational sense. And we've tried to set out what are the essential elements of conducting a time-limited trial. But there is a lot more to it. And so we are conducting a large observational research study right now in 6 hospitals, or five ICUs in 6 hospitals across the US, really to ask this question: what is the optimal way to conduct time-limited trials? So maybe you'll have me back in a few years and let you know the result of that. And so just to sort of wrap up, we've talked about these 2 pieces of our common language, need and goals of care. And what I've been trying to demonstrate is it's not just about the words that we use. It's the idea that we can examine our language to learn more about things that are blind spots to us that are embedded in clinical care. And maybe just knowing about those blind spots can really help us reconsider and make space for those moments where we need to keep our patients in view. And second, that we have moments that are well suited for deliberation that are already within our standard care processes. And if we are a little bit more aware of why we tend to skip those, perhaps we can also reinforce the dotted lines and create actual steps where we stop and talk with our patients about what's most important to them. And that finally, time-limited trials is one of these strategies, perhaps, that could reshape these patterns of care. And so with that, a lot of this work that I've been presenting today, these are 2 of my mentees who have gone on and have published some of the papers that I talked about, and I'd really like to highlight their brilliance. And this has been a big team work. And then this is my interprofessional ICU team in Wisconsin. This is our little Badgers thing. So a lot of this work I can't do without them. And then thank you so much for having me. I'm happy to take, I think we have a few minutes for questions.
Oh, great. Thank you so much. I found that really enlightening and really accurate, I think, to how which language we need and language goals of care. I was wondering if the language of goals of care is kind of euphemistic. And do you think there are times when using euphemisms is helpful, or do you think it almost always obscures what is really happening? Hoping you could say a little bit more about that.
Yeah, I think that's a phenomenal point. And one of the things I thought about when we were sort of trying to expose this use of goals of care and think carefully about how the clinicians were using it and how it's different is really, there is, I think, I'm trying to say this, I was trying to formulate how to say this without using the word need, but I'm going to use the word need. So clinicians have a need to have shorthand or to communicate quickly about loaded topics. And my hypothesis is that one of the reasons why these phrases like goals of care keep surfacing is because we have this need to continue, to sort of communicate, and perhaps not every moment has to unpack everything that's going on. So you may need to sort of quickly say, I'm worried about what's happening to this patient. I think we need to have like a time to pause and get everybody together and talk about this. And that, I think, is the function that clinicians are using goals of, like, oh, this patient needs goals of care. It's not, I don't think it's a derogatory thing. It's coming out of this need to have shorthand. Instead of, and perhaps sometimes it slides into the euphemism space, but I think it's a little bit different. It's that we need a way to sort of quickly communicate about complex topics. And as a clinician myself, I have a little bit of empathy for this idea that not that we need to keep it secret, but that perhaps not every moment is the time to fully flush this out, with, family members, or there may be a different way that you would want to sort of present particular data to a family in a different kind of setting or context. So I think, as to come back to your question, it's coming out of a place, perhaps, in a good way, to say, I need a way to sort of communicate quickly about this. The place where I really worry, though, especially in these terms like goals of care that get populated into the lay media, is just a recipe for miscommunication. And I think one of the things we learned from the clinicians in our space is that families learn these words and they learn how we use them. And so we have patients, for example, that come back to the ICU, and the last time, they heard all the clinicians saying, we need to have goals of care, we need to talk about goals of care. And then they've even said, I know what that means. That just means they want to talk about stopping life support. And I don't want to talk about stopping life support. So this idea, and it just undermines the trust. So I don't have the answer to sort of how to resolve those two things, but I do think I try to keep a lot of empathy as a clinician myself who says goals of care, or I do try to avoid it now, but to be honest, I've said it quite a few times, that it's not coming from a place to be sort of intentionally. And I think maybe to say something else about the euphemisms, I also think when we say, in critical care, we were talking about this earlier today, there's a lot of euphemisms for death and dying. And I also think that comes from a place of wanting to soften the news. And it is hard to say really, really hard things. And so I think it's also a hopeful way forward to try to understand, what are people hoping to do? And if you can kind of help them explain that you're trying to soften the blow, but that's actually not what's happening, I think it helps resolve some of the sort of linguistic difficulties.
There's a question here from the online, and one of the questions is thinking about the stakeholders who have the most power maybe in the clinical system, and are there folks that you've noticed that are more open to thinking about this time-limited thing, and also are there cultural or religious differences with the groups that may be open to using this?
Right. So maybe I'll sort of take that question in two parts. I think when I think about time limit trials, or sort of my view on this, is that it is a helpful middle ground that represents what most, and knowing my population of patients is generally older adults with chronic comorbid conditions. When we ask them in sort of large population observational studies, most older adults formulate preferences around something like a time limit trial. In other words, when you sort of give them these different options, it is kind of this thing like, okay, that sounds like it fits with what is most important to me. So I'm most worried about making sure the way time-limited trials get disseminated into critical care is that it is in a way that supports patients and their families. I do have concerns that the different, in some ways, sometimes I'll put up sort of a Rorschach image about time-limited trials because I think lots of stakeholders and from different places of power see this as an answer to a lot of different problems. And one, for example, sort of cost of ICU care. Could you, sort of rein in the cost of ICU care if you somehow, use more time-limited trials? And I guess I try quite intentionally to continue to sort of focus the conversation on let's make sure that this is supporting what's important to our patients. And that's how we should formulate our measurement around time-limited trials and our expectations and sort of how we set up their objectives. The second question is very much in line with that, which is that there are some patients and some cultures and some traditions that may not align, their views on how to use life-sustaining treatment may not align with the time-limited trial sort of approach. I had two answers to that, actually. One is I think that's true, and I think it perhaps is not a strategy for everybody. And so on one hand, we could think of time-limited trials as something that we offer, and perhaps some folks, it wouldn't align with what's most important to them, and then that's just not a strategy that we pursue. But then my other answer is if you really think about it, all we're really saying is, here's what I think the next 3 days are going to be like, and here's how I'm thinking about what means for the next 3 days to go how we're hoping. Here's how I'm thinking if the next 3 days aren't going well, this is what it's going to look like. And why don't we set a time to meet again? And I'm not quite sure that there would be a lot of hesitation around that. I don't have the view that time-limited trials should be seen as a binding sort of use for limiting life-sustaining treatment. So those are my sort of two answers to get around the question.
My experience with the palliative care team, the goals of care conversation is defined differently. It functions a little bit differently. And it is actually the driver for the plan of care. And so by goals of care, the conversation is meant to include the hopes, not just of the medical team, but what are the hopes that the family and patient have for the care that is available, and whether or not what they're hoping for aligns with what is even medically possible, what is indicated, and then a plan comes together from that standpoint. And so I would say in the palliative care context, time-limited trials have been a helpful way to mitigate the tension of the medical team who really don't see it working and the family who really just wants to give it a shot anyway. Have you seen that in your research?
Yeah, and the first thing I'll say, I love your first comment, and actually I didn't get to this, but in our investigation of the goals of care phrase itself, we included palliative care physicians, and they saw themselves in exactly how you described it. So they described a notion of goals of care that is much more similar to sort of the scholarly full view. And they saw themselves as this intermediary where they taught other clinicians, or they tried to help pull the language back and the notion back to the fuller construct of goals of care. So they saw themselves as this intermediary. So I think that's absolutely, I love that comment. And I do think it is one of the common rationales provided to use a time-limited trial to resolve conflicting expectations, whether it is sort of from the medical team or the family. And I do think that is a common use. I will say one of the things we've seen in our early data is that sometimes, I think we have this view that often the medical team is the one that's hoping to maybe pursue end-of-life care, and that the family is hoping to pursue extended, life-extending care. We've actually seen time limit trials in a few cases being used by the clinicians to sort of help convince the family to sort of overcome their hesitancy around life-sustaining treatment. Say, well, we could just try it. And if we try it, we don't have to continue it forever. So I'm not saying, and perhaps in some scenarios that's appropriate or inappropriate. I'm not sort of making a value judgment on that, but we have seen, I think, in our empirical data that there is some of that as well.
Thank you so much.